ওয়ালাইকুম আসসালাম রহমতুল্লাহ বরকাত।
আচ্ছা, আমি একটা প্রশ্ন আসছিল আর কি,
জি
যে বিগবার আমাদের যে ক্লাস হয়, বাহপের যেদিন ক্লাস হয় সেদিন অন্য কোনো গ্রুপে বাহপের কোনো সিনিয়র সদস্য ক্লাস করে, মানে করতে পারে কিনা, এই প্রশ্নটা আসছিল।
এটা তো অবশ্যই না, নৈতিকভাবে অবশ্যই করা উচিত না।
হ্যাঁ, তাই বলছি আর কি, নৈতিকভাবে করা উচিত না।
এখানে আসলে আহ, ধরেন অনেকগুলা গ্রুপ এখন তো ফর্ম করছে এবং সবাই ক্লাস নেয়, এটা ভালো, এটা আমরা এনকারেজ করি। কারণ এই ধরনের ক্লাসের জন্য গ্রুপ বা এতগুলা ক্লাস কখনো বাংলাদেশে হয় নাই এর আগে, আমাদের এই 45 বছরের অভিজ্ঞতা থেকে বলছি। কাজে এটা আমরা এনকারেজ করি, তবে এটা যেন হয় না যে একটা আরেকটাকে ক্রস করে, এটা না হলেই ভালো হয়। মনে করে যেমন আমাদের ক্লাসের দিন যদি সম্ভব হয়, যেহেতু আমাদের ক্লাসটা আমরা যে সাবজেক্টগুলো আলোচনা করি এইগুলো হয়তো অন্যরা এভাবে আলোচনা নাও করতে পারে, আমার ধারণা। কাজেই ওই গ্রুপে ওই দিন যারা প্রেজেন্ট থাকবে ওরা যদি আমাদের ক্লাসে জয়েন করে তাহলে তাদের বেশি লাভ হবে বলে আমি মনে করি। এই নিরিখে অন্যান্য গ্রুপরা আমাদের ক্লাস দেখতে পারেন, তারা দেখে যদি মনে করেন যে আমাদের ক্লাসটা গুরুত্বপূর্ণ এবং তাদের ক্লাসটা অন্যত্র ট্রান্সফার করলে তারা নিজেরাও লাভবান হবেন, তাদের পার্টিসিপেন্টরাও। সেই ক্ষেত্রে আমি মনে করি যে এই দিন আমাদের গ্রুপের কেউ তো ক্লাস করা উচিত নাই, অন্য গ্রুপরাও যদি আমরা একে অন্যের প্রতি সহানুভূতিশীল বা শ্রদ্ধাশীল থাকি, আমার মনে হয় আমরা ক্লাসগুলো লিমিট করতে পারি। কিন্তু আমরা এই ডিসিশন তো ধরেন আমরা চাপাই দিতে পারি না, সেটা হলো জাস্ট এটা আন্তরিকতার ব্যাপার। কাজে কেউ যদি ক্লাস চালু রাখেন আমাদের কিছু করার নেই, আর যদি না রাখেন তাহলে তাদেরকে আমরা ধন্যবাদ জানাতে পারি আর কি। ইট ইজ আপ টু ইউ। কাজে এটা কোনো সমস্যা না। যারা মনে করবেন আমাদের ক্লাসটা শুনলে তাদের বেশি লাভ হবে তারা আসবেন, যারা মনে করবেন অন্য ক্লাসে তাদের সুবিধা বেশি তারা ওইটাতে যাবেন, কোনো সমস্যা নাই। তবে আমাদের পরিষদের কোন সদস্য এই দিন ক্লাস করা তো ঠিক নাই, বরং তার এই ক্লাসগুলা শোনা উচিত এবং অন্যদেরকেও শোনার জন্য তাগিদ দেওয়া উচিত। ধন্যবাদ। আমরা কি ক্লাস শুরু করতে পারি? পাটোয়ারি সাহেব।
জি স্যার, আমি রেডি আছি। আপনার স্ক্রিন শেয়ারটা দিন।
আচ্ছা, জি জি, তাহলে আমার মনে আমি কিছু রিভিউ করি এর মধ্যে যারা আসলেন।
স্যার, আমরা রিভিউ সহ প্রোগ্রামে ঢুকতে চাই স্যার। আপনি হ্যাঁ স্ক্রিন শেয়ারটা দিয়ে দেন, আমরা রিভিউ সহই আমরা হচ্ছে যে ইয়ে করছি। আর আরো কিছু কথাবার্তা যেটা আমরা ক্লাসে আপনি বলেছিলেন, সেটা হচ্ছে আমাদের যে কন্টিনিউয়াস মেডিকেল এডুকেশন আর আমরা যে পরিষদের পক্ষ থেকে দেব সেই সংক্রান্ত কিছু বিষয় সবার অবগতির জন্য আমরা বলবো। প্লাস যারা উপস্থিত আছেন তারা যদি হচ্ছে যে দয়া করে ক্লাস করতে করতে খুব একটা অসুবিধা হওয়ার কথা না, আপনারা আপনাদের পূর্ণ নাম এবং মোবাইল নাম্বারটা যদি হচ্ছে যে আমাদের কমেন্টস বক্সে দিয়ে দেন, তাহলে আমরা ওই ট্র্যাকটা একটু আমাদের জন্য সুবিধাজনক হবে। আমরা এমনিতেও রাখতে পারবো, অসুবিধা নেই, যখন অ্যালাউ করি সবার নাম আমি লিপিবদ্ধ করে নিচ্ছি, কিন্তু নাম ফোন নাম্বারটা যদি দিয়ে দেন একেবারে আমার জন্য ওইটা কি করা লাগে না, এক নাম্বার। 2 নাম্বার হচ্ছে আমরা যারা জয়েন করতে পারবো না টেকনিক্যাল প্রবলেমের কারণে, তারা আমাদের ফেসবুকে যে লাইভটা হবে সেখানে ওনারা জয়েন করে কমেন্ট সেকশনে আমাদের যদি হচ্ছে যে তার পূর্ণ নাম এবং ফোন নাম্বারটা দিয়ে দেন, তাহলে আমরা সেখানেও একটা ট্র্যাক থেকে যাবে, আমরা ওখান থেকে হচ্ছে যে এন্টার করে নিতে পারবো, আমাদের ডেটা এন্টার করে নিতে পারবো। এই বিষয় আর কি স্যার। তো ওই বিষয়গুলো আমরা একটু আমাদের যখন লাইভে বলে দেবো। আর ওই লাইভে হচ্ছে যে আমাদের ভিডিওটা দেখবে, লাইভ যতক্ষণ চলবে ওই চলাকালীন সময় যে কমেন্টস গুলো আসবে আমরা সেগুলোকেই শুধু অ্যালাউ করব, অন্যগুলোকে অ্যালাউ করব না আমরা। বিকজ অফ রেকর্ডেড লেকচার অনেক শোনা যায়, কিন্তু রিয়েল টাইমে যিনি থাকবেন আমরা মনে করি তিনি আসলে আমাদের ক্লাসটাকে গুরুত্ব দিয়েই থাকছেন। ওই জন্য আমরা শুধু ওই সময়ে যারা কমেন্টস করবে এবং তার নাম ফোন নাম্বার দেবে আমরা তাদেরকে আমাদের সিএমইর আওতায় কাউন্ট করুন। জি স্যার।
জি জি, আমিও মনে করি যে আমাদের এই উদ্যোগটাও একটা কমেন্ডেবল উদ্যোগ বলে মনে করি, কারণ বিদেশও আছে। আমি আগে বলছিলাম যে তারা সিএমই বলে, কন্টিনিউ মেডিকেল এডুকেশন নাম দিয়ে, যারা সার্টিফাইড ডাক্তার, যারা লাইসেন্স ডাক্তার, তাদের বাধ্যতামূলকভাবে ওই সিএমই তে অ্যাটেন্ড করতে হয়, নতুবা তাদের লাইসেন্স নবায়ন করে না বিদেশে। তা আমরা তো ধরেন জাস্ট এটা পার্টিসিপেটরি, এই জন্য যে যারা আমাদের ক্লাসে জয়েন করবেন আমরা তাদেরকে একটা সনদ দিতে পারি, জাস্ট পার্টিসিপেশনের সনদ, যে তিনি আমাদের অনলাইন সাপ্তাহিক ক্লাসে এই জানুয়ারি মাসের 1 থেকে একদম ডিসেম্বরের 30 পর্যন্ত তিনি অ্যাটেন্ড করেছেন। তো এই অ্যাটেন্ডেন্স সার্টিফিকেটও কম কথা না, কারণ আমাদের 1 বছরে 100টা ক্লাস হবে অন্তত, যেহেতু সপ্তাহে 2টা করে 100টা ক্লাসের মধ্যে হবে। তাই 100টা ক্লাসের মধ্যে তো বিভিন্ন সাবজেক্ট হোমিওপ্যাথির উঠে আসে। কাজে এই ক্লাসগুলো যে যিনি অ্যাটেন্ড করবেন তার তো আমি মনে করি কন্টিনিউ মেডিকেল এডুকেশনের যে উদ্দেশ্য এটা পুরোপুরিভাবেই সফল হবে। কাজে আমি সবাইকে আহ্বান জানাই আপনারা পার্টিসিপেট করেন, এবং ওই যে আপনাদের যে এখানে যে নামটা যে উঠে, অনেকের দেখা গেল যে নাম উঠে না, শুধু মোবাইলের নাম উঠে, এটা কারেকশন করে দেন, এখানে চেঞ্জ করে নাম লেখা যায়। এটা করলে আমাদের পক্ষে রেকর্ড করা সুবিধা হবে। আমার মনে হয় পারভেজ সাহেব আমরা শুরু করতে পারি, আপনি স্টার্ট করেন। হ্যালো।
জি স্যার। জি জি স্যার, আমি শুনতে পাচ্ছি। আমি জাস্ট ওই ফেসবুকে লাইভ। জি জি জি
জি জি।
বিসমিল্লাহির রহমানির রহিম। আসসালামু আলাইকুম ওয়া রাহমাতুল্লাহি ওয়া বারাকাতুহু। সবাইকে আন্তরিক শুভেচ্ছা অভিনন্দন জানাচ্ছি বাংলাদেশ হোমিওপ্যাথিক পরিষদের পক্ষ থেকে। উপস্থিত গুগল মিটে আমাদের ক্লাসে যারা যুক্ত আছেন এবং ফেসবুক লাইভে যারা আমাদের সাথে যুক্ত হবেন, প্রত্যেককে আবারও ধন্যবাদ জানাচ্ছি। আপনারা আপনাদের এই কর্মব্যস্ত সময়ের মধ্যেও আমাদের সাথে যুক্ত হয়েছেন এবং আমাদের এই সিএমই কন্টিনিউয়াস মেডিকেল এডুকেশন এর আওতায় আমরা যেই গত সপ্তাহে ঘোষণা দিয়েছিলাম, আমরা আমাদের পরিষদের পক্ষ থেকে আমাদের এই ক্লাসে যারা নিয়মিতভাবে যুক্ত থাকবেন এবং ন্যূনতম একটা উপস্থিতি যাদের থাকবে, আমরা তাদেরকে পরিষদের পক্ষ থেকে সার্টিফিকেট দিয়ে তাদেরকে সম্মানিত করব এবং এই উপস্থিতিতে আপনারা নিশ্চয় পাবেন, ক্ষতিগ্রস্ত হবেন না, আমরা সেটা বিশ্বাস করি। এই বিষয়ে একটি কথা আপনাদেরকে বলে দিতে চাই, তা হচ্ছে আপনারা যারা ক্লাসে যুক্ত থাকবেন, যুক্ত হয়েছেন বা হবেন, তারা প্রত্যেকেই আমাদের এই ক্লাস চলাকালীন সময়ে একটু কষ্ট করে যদি আমাদের গুগল মিটের কমেন্ট সেকশনে আপনার নাম এবং ফোন নাম্বারটা যদি এন্টার করে দেন, লিখে দেন, আমাদের জন্য আপনাদের ডেটাগুলো সংরক্ষণ করা সহজ হবে। এবং যারা গুগল মিটে নিজের নাম, পূর্ণ নাম না দিয়ে যারা অ্যাটেন্ড করেন, তাদেরকেও বলবো আপনারা নামটাকে এডিট করে নিয়ে পুরো নামটা দিয়ে যদি আপনি আমাদের ক্লাসে জয়েন করেন। অনেকেই অনেক সময় যে একটা নাম দিয়ে বা আননোন নাম দিয়ে, আননোন মেইল দিয়ে লগ ইন করে আমাদের ক্লাসে যুক্ত হন, আমরা দেখি, বুঝতে পারি। তাদেরকে বলছি তাহলে আপনাদের একটা ট্র্যাক আমাদের কাছে থাকবে। এবং যারা পার্টিসিপেট আমাদের যখন বেড়ে যায়, 100 ক্রস করে যায়, তখন আপনি হয়তো ক্লাসে যদি আবার যুক্ত হতে না পারেন, আপনার ব্যাপারে একটা আপনাকে সলিউশন দিচ্ছি, তা হচ্ছে আপনি আমাদের সরাসরি ফেসবুক লাইভ, আমাদের বাংলাদেশ হোমিওপ্যাথিক পরিষদে যে পেজটি আছে সেখানে জয়েন করবেন এবং সেখানে গিয়ে কষ্ট করে আবারও একটু নাম এবং ফোন নাম্বারটা এন্টার করে দিলে লাইভ চলাকালীন সময়ে আমরা আপনাকে কাউন্ট করে নেব যে আপনি আমাদের গুগল মিটে জয়েন করতে পারেননি, কিন্তু আমাদের ফেসবুকে আপনি যুক্ত আছেন, আপনি নিয়মিতভাবে আমাদের সাথে ক্লাসে থাকছেন। সেই হিসেবে আমরা আপনাকে আমাদের ক্লাসের অংশ হিসেবে কাউন্ট করে নেব এবং লাইভ শেষ হয়ে যাওয়ার পরে আমরা আসলে আর কাউকে এই আমাদের যে সার্টিফিকেট কোর্সের আওতায় আমরা আর কাউন্ট করবো না যদি আপনি অ্যাটেন্ড করেন। তো আজকে আমরা আমাদের ধারাবাহিক আলোচনায় যে আলোচনাটা করছি, গত ক্লাসেও আমরা আলোচনা করেছিলাম ক্রনিক ডিজিজ, যেটাকে আমরা সংক্ষেপে সিকেডি ও রেনাল ফেইলর, এই বিষয়ে আলোচনা চলছে আমাদের। ইংলিশ ভার্সনে আজকে দ্বিতীয় ক্লাসটি আমাদের অনুষ্ঠিত হবে। ক্লাস নিচ্ছেন আমাদের বাংলাদেশ হোমিওপ্যাথিক পরিষদের সম্মানিত সভাপতি ডক্টর শেখ ফারুক ইলাহি স্যার। আজকেও তিনি তার আগের ক্লাসের কিছু রিভিউ করে দেন আজকের ক্লাসটা শুরু করবেন। আশা করছি আমরা আজকেই উনি সিকেডির ইংলিশ ভার্সনের ক্লাসটিকে শেষ করতে পারবেন। এরপরে আমরা এই সেম ক্লাসটি আমরা আবার বাংলা ভার্সনে আপনাদের সামনে উপস্থাপন করব ইনশাআল্লাহ। তো আমি সময় নষ্ট না করে আমাদের সম্মানিত সভাপতি ডক্টর শেখ ফারুক ইলাহি স্যারকে তার আলোচনা উপস্থাপনের জন্য বিনীত অনুরোধ করছি। স্যার।
Thank you, Dr. Anwar Patwari. And students, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, Adab. We are continuing our previous lecture on chronic kidney disease or CKD and renal failure homeopathic approach. So let just short review, then I will go to the lecture today. So in the review, we can say in the last class, we are new today, so they may understand it better. We said renal failure means the excretory function, and this failure leads to retention of waste products of metabolism in the blood of kidney. And so these are the functions a healthy kidney will perform. But when it fails, so all will be reversed. Before it was physiological function, now there will be pathological functions of the kidney, of the diseased kidney. So we categorized renal failure into three categories. Acute end stage renal failure. Little bit about, just I'm going a little bit faster. Acute renal failure means, you know, it is acute. It means days or maybe weeks. So this is
আসসালামু আলাইকুম স্যার, শুনতে পাচ্ছেন স্যার? হ্যালো স্যার, আপনি কি আমাকে শুনতে পাচ্ছেন? হ্যালো স্যার। স্যার, আপনার ওখানে নেটওয়ার্কের মনে হয় একটু দুর্বলতা আছে, যার জন্য হচ্ছে অডিওটা ভেঙে ভেঙে আসছে স্যার, স্পষ্ট না। আচ্ছা, যারা ভিডিও অন করে রেখেছেন আপনাদের কাছে বিনীত অনুরোধ, আপনারা ভিডিওগুলোকে একটু বন্ধ করে দেবেন এবং মাইকগুলোকে মিউট করে রাখবেন। কষ্ট করে ভিডিওগুলোকে বন্ধ করে দেবেন। কারণ ভিডিও অন থাকলে অন্যদের কনসেন্ট্রেশন একটু নষ্ট হয়। ক্লাস চলাকালীন সময়ে আপনারা প্রত্যেকেই ভিডিও বন্ধ করে দেন। শুধুমাত্র আমাদের সমান ডক্টর শেখ ফারুক এলাহী স্যার ওনার ভিডিওটা অন থাকবে। আপনাদের প্রত্যেকের স্ক্রিনে ক্যামেরার একটা সিম্বল আছে, ওটার উপরে টাচ করলেই ভিডিওটা বন্ধ হয়ে যাবে। স্যার কথা বলবেন, আপনার ছবি দেখতে পাচ্ছি স্যার, প্রেজেন্টেশনটা হ্যাঁ আসছে স্যার। স্যার আপনার মাইকটা মিউট করা, একটু আনমিউট করে নেবেন স্যার। জি স্যার, হ্যাঁ এখান থেকে আপনাকে গিয়ে আনমিউট করতে হবে মাইকটা। জি স্যার, থ্যাংক ইউ
Yes,
স্যার।
I already did it. You can hear me?
ক্লিয়ার
Okay,
স্যার, থ্যাংক
okay.
ইউ।
So acute renal failure means the loss of kidney function which develops within few days or weeks. And when we say that kidney failure started, when the serum creatinine level will go beyond 2.25 milligram. So this is acute renal failure. Now, there are causes of acute renal failure, why kidney fails acutely. So we can divide the causes into three groups. One is pre-renal, one is renal, and post-renal. Pre-renals mean the cause is before kidney. It means if there is a severe blood loss or fluid loss from the body, severe diarrhea, severe blood loss, severe bleeding, this can cause acute renal failure. Then heart failure, acute heart failure, it can cause also acute renal failure. Then there are renal cause. It means by the disease of kidney itself. There are glomerular disease, interstitial disease, so many diseases of the kidney can cause acute renal failure. And there are some other cause which is post-renal, means beyond kidney, after kidney. It means if both the ureters are blocked by renal stones, tumors, or maybe by inflammation, also there may be acute renal failure. So how can we know that the kidney is failing? Say a person is having severe bleeding and bleeding, or maybe he's losing fluid from the body by severe diarrhea and cholera. Then if his kidney fails, we'll find the symptoms. He will have anorexia, nausea and vomiting. He will start vomiting. He will have drowsiness, apathy, confusion, muscle twitching, and there will be respiratory distress, dyspnea due to pulmonary edema, and there will be bleeding from various parts due to platelet dysfunction. So this will give a hint that his kidney is failing, and at the same time the person's urine output will be reduced. Daily our urine output for a normal person is 1.5 liter. It means 1.5 liter of urine a person usually passes from the body. But this will be reduced less than 500 ml, only less than half liter. If you find this is called oliguria, or maybe the patient will have complete absence of urine. There will be anuria. So then you will make some tests, his serum, urea, and creatinine, and you will find that these are very high. His electrolyte imbalance occurred. So we know that he has acute renal failure. Now, how to treat acute renal failure? You see, acute renal failure can be treated without treatment. It means without drug treatment, only by management. But here nowadays, they don't do it like this. They make a good follow-up in the hospital. And if they find that it is not improving, then they make dialysis for limited period. But usually you can treat a patient of acute renal failure where there is no dialysis facility only by giving some measures I am mentioning. first of all, you will have to determine the cause of acute renal failure. If you find that the patient is having severe diarrhea or severe bleeding, you will have to stop that one, because this is causing acute renal failure. So you will have to stop bleeding. You will have to stop his diarrhea and vomiting. And then you will have to control his fluid loss, because he lost so much fluid. You will have to give measured amount of fluid and electrolytes. And at the same time, you will have to check his sodium and potassium. Maybe there will be hyperkalemia. So you don't give him any food which contains potassium, like banana, like citrus fruit, orange. This thing you don't give him. And you make a restriction of protein and energy intake. You limit his protein intake, meat, only maximum 40 grams per day, and you don't give more protein. And also you have salt restriction. You don't give him much salt, only very little salt. And you keep him in a bed rest for about 1 week or 2 weeks. And how you know that his kidney failure is recovering? First of all, he will start passing more urine. You will find you will have to make a countdown of his urine amount 24 hours. So if you find that he is passing before 500 ml of urine, now it is 750 or maybe 1 liter or maybe 1.5 liter, then you know that his kidney is recovering. And at the same time, if you do some tests like serum creatinine and his electrolytes, you find that these are going to be to the normal level. So you know that his acute renal failure is recovering. And you know, in uncomplicated cases, about 80%, about 90%, they come to normality. Only very few, they develop into chronic renal failure. 80 to 90 just come back to normal. But if there is multiple organ failure or there is severe infection, that case may lead to chronic renal failure. It may not recover, rather it will go to develop chronic renal failure, and this is also 50 to 70%. So when a person is having acute renal failure, you must take good care so that his kidney recovers its function and does not progress to chronic renal failure. Now let us come to our actual subject today. This is chronic renal failure. This is very, very important because you see many of our homeopathic colleagues, I am sure they are getting many cases of chronic renal failure for treatment. Because once a person is having chronic renal failure and he goes to a nephrologist will say that maybe he will need dialysis. His case is very much advanced. And he will advise him to prepare some adventitious fistula and other things to prepare for dialysis. And sure, many of the patients will not agree and they will try to find alternative treatment. And they come to homeopathic doctors, maybe they will go to other alternative physicians. So in that case, you have a great responsibility to do further responsibility, because you will have to understand in what stage this patient has come to you, whether it is recoverable or not recoverable, and what is the stage of his disease condition. So these are the things, if you understand, you can manage his case wisely, and maybe the patient will have much benefit. But if you don't understand such thing, you will not manage his case in a good way, and maybe he will have deterioration of his renal function, and soon he will die of renal failure, heart failure, or he will go to irreversible renal failure, means end-stage renal failure. So for a homeopathic physician, it is mandatory to understand the pathogenesis, pathology, signs, symptoms, and its prognosis of the chronic renal failure. So you see, chronic renal failure implies a long-standing and usually progressive impairment of renal function. Its renal function is not acute that it will recover. It is progressive. Kidney is being damaged progressively. Say it was 25% damage, then it will go to 40%, then 50%, then 70%, then 90%, like this. So there will be progressive impairment of renal function and renal physiology. So we have to understand first thing that why this renal failure occurs. What are the causes of chronic renal failure? So that we can take care it does not occur in your patients or in other persons. So here are causes of chronic renal failure. We can just see this etiology. You see 5 to 25% it is hypertension. From high blood pressure, 5 to 25% of renal failure occurs. Then from diabetes it is more. It is about 40%. 40% of renal failure patients, if you ask them, do you have diabetes? You will say, yes, I have diabetes. So this diabetes and hypertension, these are the two prime diseases which cause chronic renal failure and end-stage renal failure. End-stage means when there is irreversible renal failure. It will never come back to normal, only it can be dealt with by dialysis and transplantation. This is called end-stage renal failure or ESRF. We'll discuss more what does it mean later on. And there are other diseases also, you see. There are some glomerular disease, some kidney disease, like chronic glomerulonephritis, then nephrotic syndrome, and other interstitial diseases. These are the diseases of the kidney itself. So mostly diabetes mellitus, high blood pressure and kidney diseases, they cover about more than 80% of the renal failure. So we must take care of hypertension in a patient and diabetes in a patient. If these are uncontrolled, he will have progressive renal failure. So if he came to you with serum creatinine maybe 2.5, very soon he will go to 7, 8, 9 like this. So you take care that his hypertension and diabetes mellitus are within normal level. Now what are the clinical features? What are the signs symptoms of chronic renal failure? Chronic kidney disease means chronic kidney failure. You can say CKD or CRF. So in early stage, when renal failure starts, chronic kidney disease starts, the patient will have no symptom mostly. He doesn't know that he has chronic kidney disease or his kidney is failing. So maybe he went to doctor for other causes. And the doctor by chance, he sent him for a urine examination. And he finds there are a lot of protein in the urine, albuminuria, 3+. So the doctor will suspect, do you have diabetes? He will say, no, maybe he will say, I don't have diabetes. So he will send him for renal function test, serum creatinine, blood urea, and then he will find maybe his serum creatinine is already 5, 6, something like this. So in that way, it is diagnosed. So most of the patients, they do not know that they have kidney disease. Only by chance it is detected. But this also, say if his GFR, we'll discuss what is GFR, glomerular filtration rate, it is normal is 80 to 120. When the GFR of a person decreases below 20, he must have symptoms. He must have symptoms. Only when it is more than 20, he may not have symptoms. So ultimately he will have symptoms, but that time there will be no chance to recover. Maybe his kidney has been damaged too much. So it is better for elder persons to check up their blood and urine. I told you the other days, every 6 months or maybe even once in a year, still it is better. Because if you think that, oh, I don't have any symptoms, I don't have any complaint in the body. It means I am okay. No, you may not be okay. So it is better to make a routine test every 6 months for a person more than 40 years. Then when there will be symptoms, we will find symptoms. What symptom? The first thing there will be nocturia. Nocturia means frequent and more urination at night. The person will have, he will complain that every night I'll have to wake up 4 to 5 times to pass urine, and I cannot sleep. My sleep is very much disturbed. But in daytime, I don't have such frequent micturition. So this is called nocturia. More urination, more and frequent urination at night. So this may be the first symptom of a person. Then he will have symptoms due to some specific system, because the renal failure will affect all the systems of the body. So we can here discuss according to system what are the symptoms of chronic renal failure. First thing, anemia. This person will have anemia, sure. A chronic renal failure patient, of course, you will have anemia. Now, what are the causes why this anemia occurs? How? First thing is, you see, this is called relative deficiency of erythropoietin. We know that kidney secretes one hormone. This is called erythropoietin. So when kidney fails, he will not produce this erythropoietin. And this erythropoietin is needed for erythropoiesis in the bone marrow. This erythropoietin will go to bone marrow and it will stimulate the bone marrow to produce blood. So if there is no erythropoietin, bone marrow will not produce blood. So this person will have anemia. Second cause is toxic effects of uremia on bone marrow, because there is more urea. This is called uremia. Uremia has a toxic effect on the bone marrow itself. So also this will cause anemia. And also there will be reduced red cell survival. I told you the other day, our RBC survives 120 days. After 120 days, they die. But in renal failure patient, this duration will be lessened. This will be less than 100 days. So there will be more destruction of RBC and there will be anemia. And also the patient will have less dietary intake because he will have anorexia, distaste for food, loss of appetite, he cannot take more food. And also his intestine will absorb less iron from his food materials. So all these will cause anemia in chronic renal failure patient. But the most important cause is deficiency of erythropoietin, because kidney is unable to produce enough erythropoietin for erythropoiesis. Next, we come a very important complaint. This is called renal osteodystrophy. What happens? We must know that vitamin D metabolism. You know, we have enough vitamin D precursor in our skin. We don't need to take vitamin D from food. If you go to sunlight for a good time, there will be enough vitamin D in your body. So this vitamin D has 3 forms: vitamin D1, vitamin D2, vitamin D3. So in the skin, it remains as the precursor of vitamin D. This is acted upon by sunlight, and this will transform this precursor into vitamin D1. This vitamin D1 will go to liver through blood. Liver will act upon it and make it or convert it to vitamin D2 from vitamin D1 from vitamin D2. Then this vitamin D2 will go to kidney. Then kidney will do the final conversion. Kidney will do the conversion and make vitamin D3, which is the active form of vitamin D. So you see the role of kidney. Kidney converts vitamin D into its active form. Then this vitamin D will go to intestine, and this will help absorb calcium from the food materials. Otherwise, all the calcium you take with food, this will go through your stool. So here kidney comes into action. So if the kidney fails, it cannot make vitamin D3, and you lose all your calcium in your food through your stool. So you don't have vitamin D3 and you don't have calcium. So if you don't have calcium, then your bone will suffer. From your bone, the calcium will come to the blood, and there will be osteoporosis, there will be osteomalacia, your bone will be deficient. See? And there will be bone diseases. And also, because there will be less calcium, this is called hypocalcemia. The less calcium level in the blood, and you may have tetany. This is called convulsion. Why convulsion? Because your blood needs an optimum level of calcium, and because you don't have vitamin D3, it cannot take calcium from your food, so there will be less calcium in your blood, and you will have tetany. So you see, this is called renal osteodystrophy. So one chronic kidney disease patient will suffer from renal osteodystrophy. Then come to myopathy. Due to poor nutrition of the kidney failure patient and vitamin D deficiency. And there is also another thing I am not going to discuss because many may not understand. This is called hyperparathyroidism. Due to this vitamin D3, there will be, I told you, calcium will come out from bone into blood. So there will be hypocalcemia. To make good this hypocalcemia, our parathyroid gland will be activated, and it will secrete parathyroid hormone. And this parathyroid hormone will do some act. I'm not going to say the details. So there will be bone problem as well as muscle cramps. And the patient will have this called restless leg syndrome at night. Patient will lie down in the bed at night and his foot will move like this. This is called restless feet automatically. One can say this is the symptom of zinca metallicum of homeopathic medicine. Yes, but there are other medicines which have this symptom, but this is due to vitamin D deficiency and hyperparathyroidism. There is muscle cramps and it causes restless leg syndrome at night. So this is another symptom of chronic kidney disease. Then there will be endocrine abnormality, endocrine hormonal abnormality. You see, number of hormonal abnormalities like hyperparathyroidism. I told you there will be hyperparathyroidism, and there will be hyperprolactinemia. There will be more prolactin in the blood. For this, a woman will have amenorrhea and galactorrhea. Women will complain that my menstruation was normal, now I don't have mens. There is amenorrhea, and also she will have milk in her breast, though she does not have a baby. Say for example, without pregnancy or childbirth, she will have milk in her breast. This is called galactorrhea. Why? Because due to hyperprolactinemia, which occurs in chronic kidney disease. So this is another symptom. A woman suffering from chronic kidney disease will complain that I have amenorrhea, and at the same time I have galactorrhea. I have too much milk flowing from my breasts, and there will be loss of libido. This for hyperprolactinemia, there will be sexual desire will be lost and sexual dysfunction in both sides. So these are all endocrine abnormality in a chronic kidney disease patient. Then there will be cardiovascular disorder. This chronic kidney disease will affect all the systems of the body. So we are just here enumerating the important ones. Cardiovascular disorder, what will happen? So a chronic kidney disease patient will develop hypertension. Maybe he did not have hypertension before, but now after chronic kidney disease he will develop hypertension. And this hypertension again will damage kidney further and further. You see, chronic kidney disease brought up hypertension. Now this hypertension again killing kidney. So there will be a vicious cycle. And hypertension, why it will occur? Because there will be more, there are three causes. One is why hypertension occurs, sodium retention. In kidney failure patient, we retain more sodium in the body. So sodium will push your blood pressure up. Then there will be hypersecretion of renin by the kidney. This is also a hormone. This renin. In kidney failure patient, there is compensatory secretion of renin, and this leads to hypertension. And also there will be atherosclerosis, more atherosclerosis in chronic kidney disease patient. His vessels, arteries, there will be more atherosclerosis. So there will be hypertension. So there are these three causes develop hypertension in chronic kidney disease patient, and this hypertension must be controlled. Otherwise this hypertension again will damage more and more the kidney, and it will hasten occurring of renal failure. Now you come infection. When a person has chronic kidney disease, he will have uremia. This uremia will depress your cellular and humoral immunity by depressing the bone marrow also. So when there will be loss of immunity, this person will be susceptible to be affected by more and more infection. So there will be more infection. He will have, say, pneumonia. He will have other kidney diseases, infectious diseases, more and more. Then there will be more bleeding. Why? Because the platelet function is impaired, platelet function. And also because bone marrow is depressed, there will be impaired erythropoiesis. So this person will have bleeding from many sides, and his bleeding time will be prolonged. And then gastrointestinal disorder. The patient will have anorexia, loss of appetite. He will have nausea, vomiting. And there is also increased peptic ulcer disease in chronic renal failure due to stress. So I gave you here only the important features of chronic kidney disease. There are other features also. But to make it short, we discuss. So if we summarize what happens in chronic kidney disease, there will be nocturia, there will be anemia, there will be bone diseases, there will be myopathy, restless leg syndrome, there will be endocrine abnormality, amenorrhea, galactorrhea, then there will be hypertension, then there will be more infection, there will be more bleeding, and gastrointestinal disorder like loss of appetite, nausea, and vomiting. So these are the principal clinical features of a chronic kidney disease patient. Okay. Now a very important subject we are now coming to. This is stages of chronic kidney disease. When a patient comes from nephrologist and you are a homeopathic physician, you got a case of chronic kidney disease, CKD. You will find they will write CKD stage 3, CKD stage 4, CKD stage 5 like this. And you need to understand this thing. Otherwise, your management of the patient will be defective, will not be a good one. And you may harm the patient also. So you must know what stage 1 means, what stage 5 means, and which case you should not say the patient that yes, you will recover. You cannot say a stage 5 patient that his kidney function will recover. You should not promise. Okay, stage 1, stage 2, okay. Stage 5, no. That's why you should know what stage 5 means, what stage 1 means. So this is very important. Stages of chronic kidney disease. Chronic kidney disease has, you see, 5 stages. Starting with a mildly damaged kidney and ending with end-stage renal failure. It starts with little damage of the kidney and to complete damage of the kidney. Stage 1, little damage. Stage 5, complete damage. So different symptoms and treatments are associated with each stage. And you know, this is a progressive condition. once a person have chronic kidney disease, usually he will be progressively promoting to stage and stage. Stage 1, then stage 2, then stage 3, after 6 months stage 4, after 2 years stage 5, and then dialysis. It is like this. So some case you can recover, some case you can help, some case you cannot. Only you can help him symptomatically. So we should know the thing in a nice way. Just we are going to discuss it. So your treatment, sometimes if your treatment can slow it. You see, the allopathic physician, nephrologist, their treatment of chronic kidney disease is only to slow down the progress, not to cure. They will never boast that they can cure the chronic kidney disease to normal. They will not say like this. They will say, yes, we can treat you to slow down the progress to complete renal failure. So a homeopathic physician, when you promise to a patient, you must take care, much care to say something like this. You should understand his condition, his stage, and then only you can make some comment. So, sorry, this staging, how this staging of kidney disease is done, this is done on the basis of, we call it GFR, glomerular filtration rate. What does it mean? We'll have to understand. So blood is tested to measure creatinine, urea and other waste products in the blood to see how well the kidney works. This is called estimated glomerular filtration rate. This glomerular filtration rate, sometimes when the patient comes to us, nephrology already performed this test, and we just know that what is his GFR and what is the stage. But maybe some patient will come to you without the diagnosis of chronic kidney disease. Maybe he came for there is some swelling in his leg, edema in the leg, and he has some urinary problem, and maybe you wrote for him renal function test, serum creatinine, and you find, oh, his serum creatinine is, say, 7. Then you need to make a staging of his CKD. If you don't understand, you send him to a nephrologist for this thing. You treat him, no problem, but you will have to send him to a nephrologist to evaluate his case. So a GFR, normal GFR is 80 to 120 ml. Normally, a normal person has 80 to 120 ml. And this one, when it goes less than 5, this person must start dialysis, otherwise he will die. So this is 80 to 120 normal to 5. 5 is the mark that you must start dialysis. So let us come here. This page is very, very important if you understand. I made it very simple for you so that you can understand. It is very difficult thing. It needs a good knowledge of renal physiology and pathology. I hope you will understand. 5 stages of CKD, chronic kidney disease. GFR shows how much blood the kidney filters in 1 minute. You see, what does it mean? Glomerular filtration rate. You know the glomerulus in the nephron. It filters the blood and separates its waste products. Is it? We showed before, there is nephron, there is glomerular filtration. The blood comes to the glomerulus and there is filtered, blood is filtered to take normal thing to the blood bag, and the waste products with water, it comes to the collecting tubule and then goes to the ureter as urine. So this glomerular filtration rate means in 1 minute how much blood is filtered by the kidney. This is the ability of the kidney to clear creatinine from the blood in 1 minute. So there is a formula. There is a formula. You don't need to go through this tough formula. Just I show you. You can see GFR equal to, there is a formula. You see 140 minus age in years. Say a person has 40 years. You put here 40. Then weight in kg. His weight is say for 60, right here 60. Then also cross into 0.85 if females, because female has, less GFR, so you can multiply it by 0.85. If male, don't multiply, or only up to here. Then you divide it by 72 into serum creatinine. So this is also easy. You just measure serum creatinine of the patient. Say this is 4, for example, this is 4. So in the down set line, you find 72 into 4, and above the line, you put here 140 minus age in years, then multiply by weight in kg, and you just put on the calculator and you find the GFR. So if GFR is 80 to 120, this is normal. Now according to this GFR, they have made the staging of the chronic kidney disease. These are the stage 1, stage 2, stage 3A, stage 3B, stage 4, stage 5. So as I said, our homeopathic colleagues, I am sure many or most of our colleagues do not know this staging. So this is a good chance for them to come to our lecture and to learn this thing, because he will have to deal with chronic kidney disease patients, and he need to know the staging of the kidney disease and also GFR. Now GFR, you see stage 1. This is on the basis of GFR, this staging. Stage 1 means kidney is little damaged or almost normal, because his GFR will be more than 90. So this is almost normal. But when the GFR will fall down below 90, 60 to 90, this is called stage 2. And it means kidney has at least 10 to 30% kidney damaged already. Then if the GFR falls 45 to 60 ml per minute, it means he has at least half kidney damage. 3A means 50% of the kidney finished. It has been damaged totally. Then if it falls down 30 to 45 only, it means 2/3 of kidney damage, 2/3, 30 to 44%, you see. This is stage 3B. Then you come to stage 4. This is severe decrease in kidney function. Only 15 to 30 ml, you see. There should be 80 to 120, and now it came 15 to 30. So it means 80% of the kidney finished. And in that stage, usually a nephrologist prepares his patient for dialysis. Then he will ask him that make some AB fistula. I'll tell you what is AB fistula. Prepare AB fistula for possible dialysis upon your body. He will try to prepare his patient for dialysis when he comes to stage 4. And when it comes to stage 5, 5 means less than 15 ml. It means 85% of kidney damaged. So many nephrologists will start dialysis that time. But some will still wait up to 10. When it is less than 10 ml, you must do dialysis, and if it is 5, you must. If the GFR is 5, he must start dialysis, otherwise he will die. So don't boast. I find some of our colleagues, some homeopath, he said he recovered a patient, chronic kidney disease, who had GFR only 2. So this is almost making a dead person alive. So don't boast such thing publicly, because otherwise other doctors will be just laughing upon us, because this is not plausible. a person having 2 ml GFR and you recovered him totally by homeopathic treatment, this is just impossible. You don't make some boasting. That's why you will have to understand here what is going on. And you know, kidney tissue like brain tissue. If brain tissue damaged, it will never recover. If kidney nephrons, you know, we have 1 million nephron in each kidney. So there will be 2 million nephron, 20 lakhs nephron in 2 kidneys we have. And it is said that 80% of nephron remains inactive and 20% only will work. And we are alive by the action of 20% of nephron. It means if you have 80% damage of your kidney, still you will not have signs of chronic renal failure because you have still 20%. And 20% will keep you alive and normal. But if it is less than 20%, it means if it is more than 80% damage, 90%, 95%, then you cannot survive. You will have to do either replacement therapy of dialysis or renal transplantation. So we will have to understand the science here. We cannot say everything by emotion. No. We are scientific doctors and homeopathy is a science. It is not parascience. So these are the staging. I hope I made it very simple for you and I think everybody will understand how you make the staging of the kidney. So now you understand when a patient comes from nephrologist and he wrote it is stage 4, then you know what is stage 4. He said if it is stage 3 or 2, you know what is stage 2 or 3 and decide accordingly. Now let us come to management of chronic kidney disease. How can chronic kidney disease can be managed? So this thing what I wrote here, these are the conventional management. This is not our homeopathic management which I will discuss later on. This is the conventional one, how these are managed. You see, there are several aspects of management, several sides. First thing, you will have to identify what is the underlying cause of the renal failure. What is the cause? Maybe it is hypertension, maybe it is diabetes, maybe it is kidney disease itself. Because if you identify the cause and you treat the cause itself, you see, so the case will be improved. You can manage the cause of the kidney failure. It will help in improving the kidney condition. So this is very important. First of all, to identify what is the underlying renal disease. Second thing, attempt to prevent further renal damage. Say it is kidney, say for example it is stage 3, stage 3B. So it means, you see, 2/3 of the kidney already damaged. But still this person will be alive. Why? Because he needs only just 20% of the kidney to do his renal function. So if he has 30 to 40%, is good. So you will have to take care so that further damage does not occur. If you can stop further damage, still you can help this patient to make a normal life. So second thing is to attempt to prevent further renal damage. Then to look for reversible factors which are making renal function worse. Reversible factors. If there is a surgical cause, say if there is renal artery stenosis, just you operate the renal stenosis and make it normal, you find that person is having good renal function. If it is something in the kidney, say there are many stones in the kidney and it is damaging the kidneys. So you just remove the stones and you will find the kidney function will improve. So if there is reversible factors, Also, you will have to identify and try to correct this. Then you attempt to limit the adverse effect of loss of renal function. What is the adverse effect of loss of renal function? If there is loss of renal function, we find that you will have anemia. So anemia, if it goes on, this will make heart failure. You see, it will damage his heart. So you have to correct his anemia. Then this will remove the adverse effects of anemia on the body. If you find that he has less calcium in the body, because he has renal osteodystrophy, we understand, less calcium. So you will have to correct his calcium level so that he does not have tetany or other bone diseases. So this is the stage where you will have to see what are the adverse effects of loss of kidney function, and you will have to try to correct it. So the person will have a more or less normal life. And if you find that he has stage 5 and you cannot recover his kidney function at all, then send him to dialysis and if possible transplantation. So these are the stages or steps of management of chronic renal failure. Now we just elaborate it one by one. In the beginning, when the patient comes to you, or when the patient comes to a nephrologist, what he does, he finds that nature of underlying disease should be determined, as I said here. The first thing, you will have to determine what is the cause of chronic kidney disease. If there is blood pressure, high blood pressure, if there is diabetes or kidney disease. And the degree of renal failure is assessed. Degree means this as a stage 1, stage 2, stage 3. How far renal failure has gone. And the complications are documented. What complication it has on the body. Say it has some bone problem. It has some heart problem. So you will have to find out what are the complications already occurred in the patient. Then you will have to try retarding the progress of renal failure. Say if the patient is in the stage 2 or stage 3, try to retard or stop the progress to further staging. So how can you do it? You see, once the serum creatinine exceeds 3.5 milligram, if a patient has 3.5 milligram serum creatinine, so you know that his case will be ever progressing unless there is some suitable treatment. He cannot have normal kidney again without good treatment. So when you find the patient has more than 3.5 milligram of serum creatinine, you will have to try to retard his progressive deterioration. And some patient, there is a this is variable. Some patient will develop or progress to stage 5 very fast, say within 6 months. But some patient will progress relatively slower. So maybe it will take 5 years or 6 years to go to the ultimate renal failure. So you will have to watch the patient, how the kidney damage is progressing. You see his serum creatinine, you see his GFR, and make it, say, every 3 months. So you will understand that how far it is progressing. If it is fast progressing, you will have to take utmost care. Then you will have to pay attention to the following thing. What following things means? Control of blood pressure. Yeah, as I said, blood pressure itself will damage kidney further and further. If you find the patient has kidney failure stage 3 and he has high blood pressure, and if you cannot control his high blood pressure, you find after 3 months he will progress to kidney failure renal stage 4. So blood pressure must be kept normal and it should be between 130/80. Number 1. Number 2, his lipid level. You find his cholesterol level, triglyceride may be very high. If it is very high, this will damage his kidney further. So you have to control his blood level of lipids, cholesterol and triglyceride. And then his electrolytes and fluid. You will have to understand that there are electrolyte imbalance in chronic renal failure patient. Yes, say for example, potassium, serum potassium. Serum potassium is, say it is from 3.5 to 5, it is normal. If it is 7, this is incompatible with life. If when the patient is going to 7 in the blood level, then the patient will die of cardiac damage. So you have to take care of electrolytes also. You have to make tests every few months to see his electrolyte level. If the potassium is going very high, this is dangerous. So you will have to follow up this thing: his blood pressure, his lipids, and electrolytes. And also you will have to check up his anemia. If the patient is having too much anemia, you will find maybe 5-6 gram per liter anemia, hemoglobin. Then patient will have heart failure. So you will have to try to improve his hemoglobin level. So there is, you see, erythropoietin injection. We know that kidney produces erythropoietin, which stimulates bone marrow to make blood. But kidney, because of failure, does not make erythropoietin. So there will be anemia. So what to do? Now there is erythropoietin injection in the market. So like insulin, when you have insulin dependent diabetes mellitus, you don't have enough insulin in your pancreas. So you'll have to take insulin from outside. It is same thing. Your kidney is damaged. It is not producing erythropoietin. So you'll have to take erythropoietin to stimulate your bone marrow to produce blood. So you will correct anemia by taking erythropoietin. Otherwise you cannot. Then osteodystrophy. If you find the patient has hypocalcemia because it cannot make vitamin D3. So there will be less calcium in the blood. There will be hypocalcemia. He will have bone disease. He will have tetany. So you will have to correct this calcium level either by giving calcium, or by giving vitamin D3, synthetic vitamin 3, because kidney cannot make vitamin D3 when it is failed. So like erythropoietin, you can take vitamin D3 from outside. There is a small tablet, vitamin D3. So if you can take vitamin D3, this will correct osteodystrophy. So in such patient, you will have to compromise. For anemia, you will have to take erythropoietin from outside. In osteodystrophy, you will have to take vitamin D3 from outside. Otherwise, you cannot manage this condition. Now we come. So up to this is medical therapy. And what I said, these are all conventional management of kidney failure patient. This is conventional patient. If one nephrologist will do like this, what I said here. But after all this therapy, still you find that kidney is deteriorating more and more. His creatinine was, say, for example, 6. Now came, it is 8. Maybe next time the patient comes to you after 3 months, you find it is already 9 or 10. And you will have to ask for GFR. You find it is GFR 5. It means enough is enough. This patient can no longer be recovered to his previous condition. So you will have to compromise. You will have to ask the patient that you must go to renal replacement therapy. You must take hemodialysis. Otherwise, this is incompatible with life. He will die. Now, renal replacement therapy. It may be dialysis and renal transplantation. If there is a ready donor, live donor, and if there is facility for renal transplantation, one patient can go for transplantation, but still they will make some dialysis before transplantation to make his condition in normal level. Then only go for dialysis, transplantation. But mostly you cannot do transplantation, say within 1 month or something like this. So you take time. You need time for maybe 6 months, 1 year. So this 6 months and 1 year, this interim period, you will have to remain alive. So that time, patient will do either hemodialysis or peritoneal dialysis. Hemodialysis or peritoneal dialysis. Now, we discuss little bit hemodialysis and peritoneal dialysis. Hemodialysis. I show you a picture, then we'll come back. This is hemodialysis. This, you'll have to take the blood of the patient by one channel to the hemodialyzer, this machine. Then this machine will do the function of the kidney, artificial kidney, and it will purify the blood, and this purified blood will be coming back to the patient again. This will go on for 4 hours. This will go on for 4 hours. And the patient will have all the kidney functions restored and his bodily function restored, and they will do it 3 times in a week. So here we can see hemodialysis is the standard procedure of end-stage renal failure. Nobody will do hemodialysis in stage 3 or stage 4. They will start only it in end-stage renal failure when there is creatinine, say more than 10, 12, and his GFR, mostly GFR, is 5 or less. Then they will do hemodialysis, and it should be started. You see, some patients, they do not start dialysis unless it is very, very late. Maybe before that he will die. Because if there is uremia, you know, this patient maybe suddenly he will be unconscious in the house, and he will have so much vomiting, he will have acute renal failure, and maybe he will die before he is brought to the hospital. That's why when a patient has creatinine more than 10, GFR less than 10, you must take care. You must warn him that anytime you may have an emergency situation and you may die. So prepare for dialysis. Now for dialysis, they must make one arteriovenous fistula in the hand to take more blood. Arteriovenous fistula is called AB fistula. I'll show you this fistula in the next slide. So you will have to send the patient to a vascular surgeon to make AB fistula to prepare for dialysis. What is AB fistula? And this AB fistula must be done at least 6 weeks before start of dialysis, because it takes 6 weeks to mature. Otherwise you cannot use it for dialysis. And if there is no AB fistula, maybe some patient will not make AB fistula. You don't know, I will not do it. I will die, but I will not go for dialysis. And when his dying time comes, he becomes, say, unconscious and he is vomiting and like this and that. His relatives will take him to the kidney hospital for dialysis. In that case, because there is no fistula, they will take the blood by a catheter here. This is called this subclavian catheter here, and take blood from here to the machine. So this is a little bit dangerous and uncomfortable. So it is better when he has end-stage renal failure, he should make this AB fistula. Now I show you the AB, and the dialysis will be started. This for 3 to 5 hours. Normally 4 hours. And normally 3 times weekly. But sometimes if his condition is better, it may be done twice weekly. But ideally it is 4 hours, 3 times per week. I show you the hemodialysis little bit, then come back to peritoneal dialysis. You see the fistula. This is called AB fistula. For AB fistula, what happens, because you will have to take to the machine a lot of blood. But if you puncture a vein here, normal vein, this will not give so much blood. Only little blood. But you cannot puncture every time an artery. Then the artery will be damaged artificially with the artery. Like here, I show you. You see, this is one artery and this is the vein. They will make by operation a connection here. They will connect this vein with the artery. So this arterial blood will now flow through the vein. So there will be more blood in the vein available. If they do dialysis from this vein only without connection, so they cannot do dialysis because only little blood will go. But if they connect it with the artery will give enough blood. You see, they connected the vein with the artery. Here you see, here this is called fistula. This is called arteriovenous fistula. Arteriovenous fistula. Now this vein will have too much blood and they can take. You see, this is the fistula. This is fistula. So they will put two needles. By this needle, this red one, they are taking blood to the machine, and by this needle, it is coming back to the body. You see, by this needle, blood is being taken to the machine by a pump. There is a pump like this going on, and this blood will pass to this is dialyzer. Here the purification occurs. How I will not discuss because this takes long time. Just this is a dialyzer, and the blood will pass through this dialyzer, and this will be purified. It will remove all the creatinine and urea and excess of metabolites, and the purified blood will come back through this one to the body of the patient. And this thing will go on for 4 hours. So here you see, it is coming to the machine, and machine is drawing the blood purified here, and then it is coming back to the body, 4 hours. And this is the fistula, okay? Now, some person, or in some places, say in a remote area, there is no hemodialysis center. Now what to do? The patient is renal failure and he needs dialysis. And there is no dialysis machine or center. And he cannot come to Dhaka or somewhere 3 times per week. And also he does not have enough money. Then there is another way. This is called peritoneal dialysis. What is this? Peritoneal dialysis. This is easier, very cheaper, but of course not very comfortable. This is called peritoneal dialysis, you see. I'll show you the thing. This involves an insertion of a permanent catheter into the peritoneal cavity. 2 liters of sterile solution are introduced into the peritoneal cavity for 6 hours. Then the fluid is drained and fresh dialysis fluid is taken back. It is done 4 times daily. I show you just and tell you here. Say, okay, this one is one hemodialysis unit, This is called hemodialysis unit. So this is the machine, you see. This is the patient, and blood is being taken from the body and going through this. This is the dialyzer, and from this dialyzer, blood is coming back to the patient's body. So this guy, I think you know him. This is about before 37 years, in 1986. So this was a dialysis unit at that time in Saudi Arabia, and I was working there for many years, and I was trained in hemodialysis, and that was my job there. Now let us come to, they are my colleagues. It is before 37 years, 1986. So this is peritoneal dialysis. So if a person is, you see, you need in Bangladesh, maybe it takes about few thousand, maybe 2,000 taka per dialysis session, 2,000 to 3,000 taka. And in every city, you don't have this machine. And a person is poor, a little bit poor, and he needs dialysis. That's why then we used to do, myself also, this peritoneal dialysis. How? You see, you will have to put a catheter to his peritoneal cavity. This catheter, by simple, this is called local anesthesia, we put this catheter into the peritoneal cavity. And then 2 liters of fluid, like saline fluid, we push into his peritoneal cavity. And we put the empty bag taped here. Just we put by a tape. Then we put his shirt, or say this is the t-shirt, over here. Then he will go to his work. After 6 hours, what he will do? He will open this bag. It was tucked up. Now he will rewind it, and he will just slow down, and the fluid will come back to the bag again. And he will throw this bag after 6 hours. Then he will connect another bag. This way, he will need 4 bags in 24 hours, and he can do his own work. He will put the empty bag on his abdomen. So this is called peritoneal dialysis. You put the peritoneal fluid, this solution, inside the peritoneal cavity, throw this catheter. Keep for there 6 hours. After 6 hours, take out the water. Just the patient will bow down, and the water will come back to the bag, and remove this bag, put another bag, and push this water inside the peritoneal cavity, and fold this bag here, and keep for another 6 hours. He will do his own work. After 6 hours again, he will bow down and take this water and throw, and put another one. Like this, he will need 4 bags every 6 hours for 24 hours. And this is called peritoneal dialysis. You see, a patient who has developed renal failure, it is really very, it's a suffering. It's a suffering. You cannot say this is very tolerable things. For a few days it's okay, but when he will have to go on for months or maybe years till he finds a kidney transplant. If he does not find a kidney transplant, he will have to go on doing this hemodialysis or peritoneal dialysis till he dies. But if he finds someone to donate 1 kidney and he transplants, then he is free from this menace. You see, this is not so good thing for a patient to take. The patient were shouting upon us. Some were crying. And what we do, you see, here there was a television. There are so many patients here. This is one patient. There are so many patients. There we used to put big television and put cinema to show them to enjoy the cinema so that they can forget his suffering here. Because when you are taking the blood to the machine and coming back, his body has aching and cramp in the body. He has headache. Some patient has nausea and vomiting. Some cries. Some are depressed. That's why we have to make them in an enjoyable situation. And we used to give them good food. After that dialysis is over, he will take good lunch and he will go back. And he will come again after 1 day, every alternate day he will come. And also peritoneal dialysis, you see, this is not a good thing also, because sometimes there will be infection inside. There will be peritonitis. Then you will have to remove this tube and give him antibiotic treatment to check his peritonitis. After peritonitis is healed, you will have to put the tube again and start the dialysis. Like this it will go on. Now let us come to renal transplantation. This hemodialysis and peritoneal dialysis, these are temporary management of the patient till he goes for renal transplantation. When a patient has complete renal failure, his goal is to have renal transplantation, his goal. But renal transplantation is not so easy to do within a week or within a month. So it takes some months. So by this time, he will have to go for hemodialysis or peritoneal dialysis. Now let us come to renal transplantation, what happens. Then we will finish today. But of course, the lecture will be for another one day because there is still homeopathic parts. Renal transplantation, this offers the possibility of a normal kidney function and correcting all the metabolic abnormalities of CRF. You see, if a person can get one kidney, so this will do all the function of kidney like before. So he does not need any dialysis and he will be having or he will be leading a normal life almost. But for that, he need, not anybody can give him a kidney. There must be ABO blood group compatibility. They must be of the same group, donor and receiver. And also, there is tissue matching, tissue typing. He must have compatible tissue typing. Then only one can give his kidney to a patient. So, if a patient needs a kidney, you will have to bring at least 5-6 persons. Maybe one will be suitable donor for him. So this will be selected by ABO blood group compatibility and tissue matching. And when a person is selected as a donor, then they will take one kidney from him, one kidney. And this one kidney they will put in the recipient's body, in the patient's body. One kidney. Some people may think that both of his kidney had failure, so both kidney must be removed. Then other kidney should be added to the body. No, it is not like this. I just show you here. You see, the patient will have his own kidney as before, damaged kidney, this failed kidney, atrophied kidney. But the donor's kidney will be here on the groin side, in the iliac region, right or left iliac region. This kidney and this ureter will be connected with the bladder of the patient, and this renal artery will be connected with the, you see, common iliac artery. So kidney will be here. So this guy will have 3 kidney, 2 his original one, and the third one from the donor, like this here. These are the old kidney, this is the new kidney. This is renal transplantation. And this donor kidney of 2 types. One is called cadaveric kidney, one is called live donor. Live donor means if one of his relatives wants to donate one kidney to him, then they will put them in 2 tables. In one table, one group of surgeon will take the kidney of the donor. And in other table, the same kidney will be put here on the recipient body by another team. Now, now there is no live donor, only cadaveric donor, you know. Maybe yesterday they were in the newspaper, it came that one lady, she died and 2 of her kidneys are transplanted in the bodies of 2 patients. And also 2 of her cornea with 2 patients. It is like this. So this is called cadaveric kidney. Cadaveric kidney means when a patient is dying, he has brain death. Doctor announced that he is not dead, but his brain is dead. He is still alive by artificial means. So at that time, if he or his relatives, they declare that, okay, we will donate our kidney or heart or liver to somebody who needs it, then the surgical team will harvesting both of his kidney and put in special flask or containers where the kidney will be alive. Now maybe the kidney will go to another city, to another patient. So this kidney will be transported to that city by special carrier, and there in the patient, they will do the operation and put the kidney. So this is called cadaveric kidney. And if from alive patient, donor, this is called donor kidney. Live donor. And this is cadaveric donor. Okay. Now, before I finish, I tell you, when a renal failure patient takes a donor kidney in his body, you don't think that his problem is finished. Now he will have a new problem. A new problem will start. And he will have to manage. What is this? You see, the new kidney he has taken in his body is not his own. This is foreign kidney. This is a foreign tissue. So his body will try to reject it, to kill this kidney. His body will not accept it. Now to make his body accept it, the patient will have to take 2 to 3 drugs. This is called an immunosuppressive drug. Immunosuppressive drugs. These drugs will suppress his immunity and save the rejection. His body will be suppressed. His immunity will be suppressed, so that this kidney remains alive and it can function. But what will be the problem with the patient, you see? Because he will have to take this immunosuppressive drug till his life. And this immunosuppressive drug will make him liable to many infections, because he has no immunity, very less immunity. His immunity is suppressed. So very often he may have urinary tract infection, he may have hepatitis, he may have pneumonia, something like this. So this is the struggle of struggling life, you know. When you have taken a kidney, okay, you are free from dialysis, but you will have to fight with immunity by taking immunosuppressive drugs throughout your life to keep the kidney alive. Now, this kidney may be alive for 2 years, 5 years, maybe maximum 10 years. And once this new kidney failed again, then usually second transplantation is not done. It is very difficult. So the patient will have to be continuing throughout his life on dialysis. Once the donor kidney fails, he will have to go for dialysis again and throughout his life. So this is the end of the story of chronic kidney disease. Next day, in next lecture, we'll come to our actual subject, homeopathic approach to management of CKD. As a homeopathic practitioner, what we will do, what is our duty, and how far we can help the patient to recover from chronic kidney disease. So this is a very important lecture, and there are, you see, we'll have to interpret the CKD in the term of miasm, our chronic miasm, and also we'll interpret it by our trimisms. Then we'll take all the rubrics from the repertories. There are hundreds of rubrics in the repertory for chronic kidney disease. We'll bring all here, almost all. And then we'll analyze and see what medicines mostly cover the symptoms of chronic kidney disease patients. Then we'll go on describing some related medicines for you, then we'll finish it. So this will be a very important lecture for any homeopath. So I hope nobody will miss it. And with this I am finishing. Assalamu alaikum wa rahmatullah wa ma tawfiqi illa billah. Dr. Anwar Patwari, I finished already. Now I am transferring the microphone to you. You can take some question if there is some people want to clarify, or if some people can make some commentary on our class, they are most welcome. Assalamu alaikum.
Thank you very much, sir, for your excellent class. উপস্থিতি আপনারা যারা এখনো আমাদের কমেন্ট সেকশনে আপনার নামটি লিখে দেননি, যদি আপনি নামটা এবং ফোন নাম্বারটা লিখে দেন আমাদের জন্য আপনার কাউন্টিং করাটা ইজি হবে, এবং যারা পরে যুক্ত হয়েছেন তাদের জন্য ইনফরমেশনটা আবারও দিলাম। এবং যারা আমাদের ফেসবুক পেজে লাইভ দেখছেন, এই ক্লাসে হয়তো কারিগরি সমস্যার কারণে যুক্ত হতে পারেননি, আপনি ফেসবুক কমেন্ট সেকশনে আপনার কমেন্টসটা, নাম কাউন্ট করে নেব। এ পর্যন্ত প্রায় 80 জনের বেশি আমরা কাউন্টিং এনেছি আজকে ক্লাসে। অনেকেই হয়ে আবার হয়তো সমস্যার কারণে করতে পারেননি।
ডক্টর পাটোয়ারি, আপনার একটা সাউন্ড হচ্ছে, দেখেন তো এটা।
স্যার এখনো কি হচ্ছে স্যার?
হ্যাঁ এখনো হচ্ছে
স্যার, এখনো কি কোনো শব্দ হচ্ছে?
হ্যাঁ এখনো হচ্ছে।
স্যার আমি একটু রিকানেক্ট করছি, তার মধ্যে আমি রুহুল আমিন হ্যান্ড রাইজ করেছেন, আপনার প্রশ্নটি করুন, আমি আবার ডিসকানেক্ট হয়ে রিকানেক্ট করছি।
আচ্ছা
থ্যাংক ইউ।
রুহুল আমিন সাহেব বলেন।
Dear sir, thanks a lot for delivering such nice piece about CKD. Nowadays, this is a very common disease. Main causes of CKD such like diabetes, hypertension, and painkiller medicine taken is a very common scenario. I think after hearing this lecture, we can give a better service to our patient. Today I learned the formula for measuring GFR, which is very easy to calculate, only done by one common test, serum creatinine. Previously, I thought this is a critical test done in laboratory under supervision and urologist. Sir, my question is, if we want to get vitamins D from sunlight, is it necessary to direct touch with skin, or we can get also covered by cloth?
No, it
Thanks,
must
sir.
be exposed. You cannot cover the skin with cloth. It must be exposed to sunlight. Then only sunlight will convert your precursor vitamin D into vitamin D1. Okay, thank you.
Okay,
থ্যাংক ইউ
sir.
ভেরি মাচ। জি, এ পর্যায়ে প্রশ্ন করবেন মোহাম্মদ আকবর হোসেন। আপনি হ্যান্ড রাইজ করেছেন, আপনার মাইকটি আনমিউট করে প্রশ্নটি করবেন। আর যারা প্রশ্ন করতে চান কষ্ট করে হ্যান্ড রাইজ করলে আমাদের জন্য সুবিধা হবে আপনাদের নাম ঘোষণা করতে।
আসসালামু আলাইকুম রহমতুল্লাহ।
ওয়ালাইকুম সালাম।
অত্যন্ত গুরুত্বপূর্ণ একটা ডিজিজ, এটা আসলে কমন। তো আমার সকলেরই কর্তব্য হলো সর্বোচ্চ সেবা প্রদান করা। আর এখন এইসব ক্ষেত্রে এই ধরগুলো নিয়ে আমাদের কাছে আসে। তো সেক্ষেত্রে স্যার আমার যেটা জানার বিষয়, গত সপ্তাহে আমি একটা প্রশ্ন করেছিলাম যে আসলে ডায়ালাইসিস কৃত রোগী থেকে আমরা হোমিওপ্যাথি ট্রিটমেন্ট দিতে পারি কিনা। এটা হলো আজকে যেটা আমি জানতে চাচ্ছি সেটা হলো যে ক্রিয়েটিনিন, স্যাম ক্রিয়েটিনিন সাধারণত 2 বা 2 এর উপর এরকম হইলে হোমিওপ্যাথি ট্রিটমেন্টে ম্যাক্সিমাম ক্ষেত্রে হয়তো রিকভার হয়ে আসে, কিন্তু আমরা ম্যাক্সিমাম কত পর্যন্ত, যেমন 7-8 হলে তো ডায়ালাইসিসের প্রয়োজন হয়, আমরা ম্যাক্সিমাম কত পর্যন্ত হলে হোমিওপ্যাথির দিকে ট্রিটমেন্ট করাইতে পারি? এটা হলো স্যাম ক্রিয়েটিনের ক্ষেত্রে। আর জিএফআর এর ক্ষেত্রে স্যার যেমন 3rd স্টেজ, সেক্ষেত্রে আমাদের ওই যেটা আমাদের নর্মাল হলো 80 to 120, তো ওই 3rd স্টেজ তো অনেক কমে আসে, হয়তো 25 বা এরকম। তো আমরা কোন পর্যন্ত এই জিএফআর এর ক্ষেত্রে কোন পর্যন্ত দেখলে আমরা হোমিওপ্যাথি ট্রিটমেন্ট দিতে পারি এবং সেটা রোগীর উপকার হবে এই সেন্সে, যাতে তার ক্ষতি না হয়, তার একটু জানতে চাচ্ছি প্লিজ।
Okay, thank you for your question. He wants to know up to which level of serum creatinine and GFR we can give homeopathic medicine. We can give homeopathic medicine if the patient wants, even if his GFR is 0. So, how can I say like this? Usually, I told you, this end-stage renal failure starts after below 10 GFR. When GFR is below 10, this is called end-stage renal failure. It means his kidney will not recover to normal again. So in that case, even patient comes, his GFR level is 5. Now he says, there are things you see, he cannot go for dialysis. Why? Because he's a poor man. Even if you say that you need dialysis, he cannot go for dialysis. He's poor, number one. Number two, maybe he is in a remote place. There is no dialysis. Even he cannot go for peritoneal dialysis because there is no nephrologist. So in that case, many patients come to me like this, that they will not go. Now, will you let the patient to die at home? No. You give him, then you give him symptomatic treatment. You tell the patient that you will not recover, but I'll give you for relief of your presenting complaint. So you can treat, but you should not boast to patient that he has less than 10 GFR, that you can cure him. No, you don't say something like this. Don't say something like this, what God said. You tell him, I'll try to help you as far as possible. But your kidney is in irreversible position. And if he accepts, okay. If he does not accept, assalamu alaikum. So this is the approach. But usually, GFR less than 10. This is irreversible. And we don't take serum creatinine level. We go by GFR level. GFR is more accurate. If serum creatinine may be most nephrologists, when it goes beyond 10 serum creatinine, they will send it for dialysis. But usually they will convert it to GFR to see. GFR is the better indicator. If it is less than 10, if it is less than 5, of course. If it is less than 10, they will send for dialysis. Okay, thank you. Next question.
Thank you very much. Anybody else? আর কারো কোনো হ্যান্ড দেখতে পাচ্ছি না। যদি কেউ প্রশ্ন করতে চান হ্যান্ড রাইজ করে আপনার প্রশ্নটি করতে পারেন। যদি কারো কোনো প্রশ্ন না থাকে তাহলে আমরা স্যার আজকের মতো শেষ করতে পারি।
Any commentary, you ask them. If there is anyone, I hope there is one lady from Canada. She's Shahna Siddiqa. If she's here, she can unmute and join in our discussion. Dr. Shahana Siddiqa from Canada. And there should be one from United States of America, Dr. Maria Felicity. If you are here, you can unmute and
Dr. Shahana Siddiqa is present. Our class.
Okay, you can ask her. If she is interested, she can unmute and she can join. And there is one, Dr. Maria Felicity from USA. Is there? She is there or no? Okay, if Shahna Siddiqa wants, she can join, or any other question. Still we have a little 2-3 minutes. We can take another question.
ডক্টর শাহানা সিদ্দিকা, আপনি কি শুনতে পাচ্ছেন? হয়তো কারিগরি জটিলতার কারণে হয়তো কোনো মাইকটা হয়তো আনমিউট হচ্ছে না।
Okay, then we'll finish it. I just
লং টাইম স্যার অনেকে ওই যে মিউট করে রাখলে একটা প্রবলেম হয়, অনেক সময় সেটা স্ক্রিন হ্যাং করে, আনমিউট হতে চায় না। এই জন্য বলবো আপনি যদি একটু ডিসকানেক্ট হয়ে আবার রিকানেক্ট হন, আপনার কাছ থেকে আমরা একটু কমেন্ট্রি শুনতে চাচ্ছি। আমাদের স্যার আপনাকে চাচ্ছেন যে আপনি একটু কমেন্ট্রি দেন আমাদের ক্লাসের বিষয়ে, ডক্টর শাহানা সিদ্দিকা। আর এছাড়াও যদি অন্য কেউ আমাদের ক্লাসের বিষয়ে কোনো মন্তব্য করতে চান, আপনি মাইকটা আনমিউট করে আপনার মন্তব্যটি করতে পারেন, অথবা হ্যান্ড রেজ করলে আমরা নামটি ঘোষণা করতে পারি।
Let me say something. You see, this class is important in the sense because as homeopathic physician are like GP, so all sorts of patients come to us, and any patient comes to you, you should know his or her conditions. is your heart disease condition well? So not only to select medicine from that total list of symptoms, a doctor has many other functions, because he will have to ask her diet and regimen, and he should know that what disease she is having. If she is having a gout, so you know that there are specific dietetic restrictions for her. If she has diabetes, if she has blood pressure, if she has peptic ulcer, also you have dietetic restrictions for her. So it is better if you can diagnose the condition, you can discharge your duties better. Of course, we'll select our medicine on the basis of totality of symptoms. But management needs some other thing to manage the whole condition of the patient. That's why, similarly, if a patient of renal failure comes to you, yes, Shana Siddiq, I can see you, just 1 minute I am taking, and then you can discuss. So,
Sure.
if you have a chronic renal failure, you will have to know which stage that patient belongs to. If it is stage 5, stage 2, if you know it is stage 2, it is good for you. You have chance to cure her or him completely. But if the patient is in stage 5, you take caution to comment on the cure of the patient. You don't give him too much words that you are going to cure him very soon. Just you say, yes, you have given me the responsibility, I will try my best. So far, I can help you in recovering from this condition. How much, I cannot say that fully or something like this. I will try my best to recover you as much as possible. This should be our answer only. Okay, thank you. Okay, Dr. Shana Siddiqa, you are welcome.
Ji, Assalamu alaikum, everyone. Finally, I could unmute myself. Actually, খুব ভালো লাগলো আসলে ক্লাসটা। আমি আগেও অনেক কন্টিনিউ করছি, কিন্তু এই ক্লাসটা আসলে বড়ই ইম্পর্টেন্ট এবং সত্যি অনেক ইউজফুল. So many things even we don't know. I'm practicing in Canada, actually is in very difficult situation. Healthcare is very important here. এবং we have to follow so many rules and regulations. তারপরও আমরা ইনশাআল্লাহ আলহামদুলিল্লাহ করে যাচ্ছি ভালোভাবে। তো সবাই দোয়া করবেন এবং আমরা এইভাবে আমরা একজন আরেকজনকে হেল্প করব। যে যেটুকু জানি একটু একটু করে আমরা যদি একজন আরেকজনকে হেল্প করতে পারি, আমাদের মধ্যে কমিউনিকেশনটা কন্টিনিউ থাকে, তাহলে আমরা সবসময় মনে হয় যেন কিছুই জানি না, কিছু মনে হয় যেন হ্যাঁ এই জিনিসটা তো আমি জানতাম না, এই মেডিসিনটা তো আমি ভালোভাবে পড়িনি। আসলে অলওয়েজ মনে হয় যেন খুব কম জানি, এটাই। তো আমার মনে হয় এই ক্লাসটা আমরা যদি কন্টিনিউ করতে পারি এভাবে, আজকে তো আমরা খুব ভালোভাবে শুনতে পারলাম। প্রথমে একটুখানি ডিফিকাল্টিজ হচ্ছিল শুনতে, কিন্তু এখন আলহামদুলিল্লাহ ভালোভাবে শোনা গেছে। তো এভরি বুধবারে আমরা ইনশাআল্লাহ I will try my best to join this class. So ইনশাআল্লাহ we'll be in touch. So সবাই সবার জন্য দোয়া করবেন যাতে আমরা আমাদের প্র্যাকটিস এবং মানুষকে ভালোভাবে যাতে সেবা দিয়ে যেতে পারি। Okay?
Thank you,
Thank
Dr.
you so
Sanad.
much.
I think there are some other homeopaths in your area or in Canada. So
Yeah.
you can just give our link to them. If they are interested, they can join, and sure.
Sure. There are so many. Yes. Yeah. Can we do that? Because I don't know. But আবার এখানে অ্যাসোসিয়েশন যেটা আছে, অ্যাসোসিয়েশনের মাধ্যমে আমরা আরো সেমিনার করি, যেটা ডক্টররা ইন্ডিয়া থেকে জয়েন হয়, তারপরে বিভিন্ন লাইক স্পিকাররা ইন্ডিয়া আছে, আমেরিকা আছে, কানাডায় আছে, ওরা করে, আমি ফলো করার চেষ্টা করি। কিন্তু আপনারা যদি আমাকে পারমিশন দেন, তাইলে ধরেন আমি এটা আমাদের অ্যাসোসিয়েশনে আমি লিঙ্কটা শেয়ার করতে পারি, and I can talk to them to make an arrangement.
You can. এবং আমি আপনাকে বলি, আমরা ক্লাসগুলা জাস্ট ফরেনার্সদের যারা নন বাংলা স্পিকার, তাদের জন্য আমরা এই ক্লাসটা করেছি। আমরা যে সিকিউরিটির উপর যে ক্লাসটা নিচ্ছি, আমরা প্রথমে ইংলিশে নেই, নেওয়ার পরে ওইটা আবার বাংলাতে দিই ফর আওয়ার ওন people in
own
Bangladesh.
country
Yeah,
people.
yeah.
Yes.
So we do it alternately. First we give the English version and then we give Bengali version. So during English version, you can ask them if they are non-Bengali to join, and if they are Bengali, then join in our Bengali class also.
Bengali class also. না এখানে তো বেঙ্গলি হোমিওপ্যাথ আছে কয়েকজন মনে হয় আমাদের এখানে টরন্টোতে অল্প কিছু, কিন্তু নন বেঙ্গলি বেশি, আর মনে করেন যারা ম্যাক্সিমাম ইন্ডিয়ান আছে, রাশিয়ান আছে,
So I hope they will
তারপরে
enjoy. I hope they will enjoy our
I
class.
enjoyed very much. Yes. So আমি আপনার পারমিশন পাইলাম কেন? So
Yes.
do you think if they want to contact with you, they should contact you, right?
Yes, they can. Okay.
Okay. That's good.
Okay.
That's good.
Thank you
এটা
very
তো
much.
অনেক ভালো হবে, খুব ভালো লাগলো। আলহামদুলিল্লাহ, ইনশাআল্লাহ কথা হবে। Okay.
Okay, thank you. Dr. Anwar Patwari, I think we can conclude.
জি, থ্যাংক ইউ স্যার। লাস্ট একটা কমেন্ট্রি একজন হ্যান্ড রাইজ করেছেন, ওনাকে দিয়ে আমরা শেষ করব আজকে ওনার কমেন্ট্রিটা শুনে। মোহাম্মদ কামরুল হাসান, আপনার মাইকটি আনমিউট করে প্রশ্নটি করবেন অথবা আপনার মন্তব্যটি করুন।
Assalamu alaikum, sir.
Alaikum salam.
I am so happy that, sir, I'm the great fan of you. When I was the student of Government Homeopathic Medical College, Mirpur, when you are the honorary teacher, from that time I'm very fan of you. I'm the, sir, classmate of Mohsin, your affectionate student.
I understand, yeah.
Sir, we are lucky enough, sir. We have both like you teacher, like a guardian. Actually, those who are, they are unfortunate who are attending the class, sir. They are very unfortunate, I think. We're so lucky enough, sir. And, when you start the class, regularly I try to attend your class, sir. Maybe one class I have mistaken or a gap, but regularly I try to attend, sir.
Thank you.
I'm getting mass results, sir. Thank you, sir.
Okay, welcome. Dr. Anwar Patwari?
জি স্যার, যারা উপস্থিত ছিলেন এবং শুরু থেকে শেষ পর্যন্ত আমাদের ক্লাসটাকে আপনারা প্রাণবন্ত রেখেছেন এবং সর্বশেষ আপনাদের মন্তব্য এবং প্রশ্ন দিয়ে আমাদের ক্লাসকে আরো বেশি সমৃদ্ধ করেছেন, প্রত্যেককেই জানাই আন্তরিক মোবারকবাদ, অভিনন্দন। এবং আপনারা আমাদের স্যার যেটা বলেছেন, আপনি নিজে উপস্থিত থাকবেন, আশপাশে আপনার পরিচিত হোমিওপ্যাথ যারা আছে তাদেরকেও আপনারা ইনভাইট করবেন আমাদের ক্লাসের বিষয়ে। আমাদের বাংলাদেশ হোমিওপ্যাথিক পরিষদের পক্ষ থেকে প্রতি বুধবার এবং রবিবার আমরা দুটো ক্লাস করে থাকি, অনলাইন ভিত্তিক উচ্চতর প্রশিক্ষণ ক্লাস। এই ক্লাসে আমাদের বুধবারের ক্লাসটি আমরা গুগল মিটে করি এবং রবিবারের ক্লাসটি আমরা জুমের মাধ্যমে করি। আমাদের বাংলাদেশ হোমিওপ্যাথিক পরিষদের যে ফেসবুক পেজটি আছে সেটাতে আপনারা নিয়মিতভাবে ফলো দিয়ে যদি থাকেন তাহলে আমাদের নিয়মিত এই ক্লাসের আপডেট গুলো আপনারা পাবেন। এবং আমরা আমাদের এই ক্লাসটিকে, বিশেষ করে গুগল মিটের ক্লাসটিকে আমরা ফেসবুকে লাইভ করার চেষ্টা করি ম্যাক্সিমাম সময়ই। মাঝে মাঝে হয়তো কারিগরি জটিলতার কারণে বা অন্য কোনো সমস্যা যদি থাকে আমরা সেটা করতে পারি না। এই জন্য আপনাদের আমাদের ক্লাসের বিষয়ে যদি আরো কোনো মন্তব্য থাকে, পরামর্শ থাকে, নিশ্চয়ই আপনারা লিখিতভাবে আমাদের ফেসবুকে অথবা আমাদের ব্যক্তিগতভাবে আমাদের স্যারকে আমাদেরকে জানাতে পারেন। আমরা চেষ্টা করব ক্লাসটিকে আরো কিভাবে প্রাণবন্ত করা যায়। তো আজকের মতো আমরা এখানেই বিদায় নেব। সবাইয়ের জন্য দোয়া করি, আল্লাহর কাছে আমাদের জন্য দোয়া কামনা করি এবং বিশেষ করে আমাদের স্যার যারা আমাদেরকে এই এত কষ্ট করে শত ব্যস্ততার মধ্যেও আমাদের হোমিওপ্যাথদের জন্য যেই স্যাক্রিফাইসটা করছেন সেই জন্য তাদের জন্য দোয়া করি, আল্লাহ তাদেরকে দীর্ঘায়ু দান করুন। রব্বুল আলামিনের কাছে দোয়া করি আল্লাহ আমাদের যারা মৃত্যুবরণ করেছে তাদেরকে জান্নাতবাসী করুন এবং আমাদেরকে আত্মমানবতার জন্য কবুল করে নিন, আমিন। আজকের মতো বিদায় নিচ্ছি, আল্লাহ হাফেজ। আসসালামু আলাইকুম ওয়া রাহমাতুল্লাহি ওয়া বারাকাতুহু।
ওয়ালাইকুম আসসালাম ওয়া রাহমাতুল্লাহ।